Good morning, everyone. I'm presenting on my research topic, alpha-1 antitrypsin deficiency testing in the primary care setting on behalf of the Department of Internal Medicine. So starting with a little bit of background, alpha-1 antitrypsin deficiency is a genetic condition that primarily manifests as pulmonary emphysema, but is also known to cause some extrapulmonary manifestations that include liver cirrhosis, vasculitis, paniculitis, and so on and so forth. Really, the diagnosis hinges on a low serum alpha-1 antitrypsin level, as well as a severely deficient phenotype on genetic testing. A little bit of background. So in 2003, the American Thoracic Society, as well as the European Respiratory Society, they released a joint statement that all adults with COPD or emphysema should be tested for alpha-1 antitrypsin deficiency, and that was a grade A recommendation. The reason for this recommendation was sixfold. First of all, they state that the prevalence of the disease is not negligible, between 1 in 2,000 and 1 in 5,000. Second, they say that the lung disease carries a substantial clinical burden with greater decline in FEV1 and greater mortality at a young age. They say that administration of IV augmentation therapy can improve survival and decrease progression of the lung disease. Fourth, they state that the knowledge of the genetic condition can actually motivate patients to change their health-related behaviors, things such as tobacco cessation. The fifth reason is that a positive psychological effect may be gained by knowing that they have a genetic condition that explains their pathology. And lastly is the economic benefits from testing that prevents future exacerbations of COPD as well as hospitalizations. Despite this, the disease remains very much underdiagnosed. So there have been studies that have estimated a 5 to 8 year delay between the first symptom and recognition of the actual disease. They say that up to 5% of patients with COPD are thought to have the actual alpha-1 antitrypsin deficiency, but only 4 to 5% of those with a deficiency have been identified. And in the US, they approximate that less than 10% of people with severe deficiency have been diagnosed. So this brings us to our research questions. Number one, what percentage of patients with COPD or emphysema in the Ascension St. John Internal Medicine Specialty Center have been tested for alpha-1 antitrypsin deficiency? The second question is, are there any patient characteristics that differ between those who have been tested and those who haven't been tested? The methods for our study were a retrospective chart review of adult patients seen at the IMSC between January 1st, 2017 and December 31st, 2018 who are diagnosed with COPD. So data collected included whether or not testing was ordered, whether it was completed, the serum level, the genotype, the age at COPD diagnosis, demographics, tobacco use, family history of the disease, as well as diagnosis of concomitant conditions known to be present in alpha-1 antitrypsin deficiency, such as liver disease, paniculitis, and vasculitis. And lastly, the number of ED visits for COPD exacerbation for 1 year after the office visit. We then calculated the prevalence of testing, and factors related to testing were assessed using statistical tests such as the chi-square, the student's t-test, and the Mann-Whitney U-test. In order to determine how many patients we would need to look at, we did a power analysis that was based off of a study performed in 2018 that looked at the frequency and determinants of testing for alpha-1 antitrypsin levels in COPD patients. And what they had found was that the mean age of patients who were not tested was 66 plus or minus 9 years, as well as, and compared to 61 plus or minus 10 years for patients who were tested. And to find that difference with an alpha error rate of 0.05 and 90% power, we would need 112 patients per group. This brings us to our results. So the first result I want to present is the prevalence of testing, and we included 271 patients in the study that met our study criteria. Among the 271 patients, 252 did not have an alpha-1 antitrypsin deficiency test ordered. That equates to about 93%. 19 patients did have a test ordered, which equates to about 7%, and among the patients who did have a test ordered, 16 had it completed, and 3 did not have it completed. The table we see at the bottom of this page shows that the serum alpha-1 antitrypsin level, the mean and the standard deviation, was about 157 plus or minus 39, and the genotype in all of the 3 patients that did have this performed was the normal variant genotype. The next section of our results looks at patient characteristics related to alpha-1 antitrypsin deficiency testing. The first variable we looked at was age at COPD diagnosis in mean number of years plus or minus the standard deviation. For our total population, the mean number of years was 56.9 plus or minus 9.9. In comparing those who had a test ordered to those who did not have a test ordered, the mean age at COPD diagnosis was 50.1 as compared to 57.4 who did not have a test ordered. This was found to have a significant p-value at 0.002. Moving on to sex, for our total population, there was 42% males and 58% females, and in comparing those who had a test ordered comparing to those who did not have a test ordered, there was found to be no significant difference in testing. Moving on to race, we divided it into white, black, and other or unknown. 18% of the study population was white, 73% black, and about 9% was unknown. There was found to be no significant differences with respect to testing of alpha-1 antitrypsin deficiency compared to race. Next, we looked at BMI. In the total study population, the BMI on average was 30.8, and there was found to be no significant difference in BMI as it pertains to alpha-1 antitrypsin deficiency testing. When we look at tobacco smoking, we divided it into current tobacco status, whether they were a never smoker, a current smoker, or a former smoker, as well as their overall lifetime tobacco use in pack years. So starting with the first category, we determined that there was no significant differences in testing between those of variable tobacco status. However, if we look at tobacco use in pack years, those who had a test ordered had 21.4 pack years plus or minus 16, and those who had a test not ordered had 32.6 plus or minus 24.2, and this did infer a significant difference with a p-value of 0.05. With respect to family history of alpha-1 antitrypsin deficiency testing, we could not perform any statistical analysis on this because there was no reported family history among the 271 patients in the study. With respect to chronic liver disease, we did not find any significant difference in alpha-1 testing between those who had a test ordered and those who did not have a test ordered. With respect to both vasculitis and paniculitis, we could not perform statistical analysis between the two groups because the patients with vasculitis, none of them had a test ordered, and the patients with paniculitis, the same thing goes for them. Lastly, we looked at the number of ED visits for COPD exacerbation at 1 year. And in order to determine statistical significance here that you see with a p-value of 0.04, we actually looked at the median number of COPD exacerbations at 1 year. And you can see between the test ordered group and the test not ordered group, both of them has a median of 0, but the reason there's a statistical significant difference is because there was greater variability among the group that had a test ordered as compared to the group with a test not ordered. And that is why you see significant p-values. The conclusions of our study are that patients with COPD are infrequently tested for alpha-1 antitrypsin deficiency, which may reflect under-recognition of the previously mentioned recommendation. Certain characteristics are associated with greater likelihood of testing, including younger age at COPD diagnosis, a higher number of visits to the ED for exacerbation, which can indicate worse illness severity or more frequent opportunities for testing, and also lower lifetime tobacco use. However, certain known comorbidities like chronic liver disease are not associated with greater likelihood of testing, and this may reflect clinical under-recognition. The limitations of our study include a retrospective study design. Only 19 patients had a test ordered, which is much less than the previous power calculation that we made. And lastly, testing at outside institutions can be underrepresented. The future directions of this study include a prospective study design of testing as it pertains to physician characteristics, such as education of the recommended guidelines and associated comorbidities. That's all I have today, folks. Thank you so much for your attention.